asks them to inhale deeply. They stop before the inhalation is complete because of intense pain. When the nurse palpates the right subcostal area over the inflamed gallbladder, the client feels extreme pain on inspiration. Gallstones are identified in clients who have cholelithiasis on an X-ray or an ultrasound image. Cholangiography combines radiography and a contrast medium, a dye, to outline the biliary tract. Endoscopic retrograde cholangiopancreatography, ERCP, identifies stones that are located in the common bile duct. During ERCP, a radiopaque dye is inserted through a cannula into the main bile duct, and then several X-rays are taken. In preparation for ERCP, ask the client about any known allergies or sensitivities to X-ray dye. Be sure the client has signed a consent form. On the night before the procedure, instruct the client to take nothing by mouth after midnight. Advise the client that a sedative will be administered during the procedure by IV infusion. Following ERCP, take the client's vital signs every 15 minutes until they are stable. Be sure the client receives nothing by mouth until the gag reflex returns. Complications that can develop following ERCP include perforation, sepsis, and pancreatitis. Instruct the client to report abdominal pain, fever, nausea, or vomiting to the primary care provider immediately. What are the nursing diagnoses for clients who have cholecystitis or cholelithiasis? Pain related to the passage of gallstones. Nausea and emesis related to blockage of the flow of bile. Altered nutrition, less than body requirements related to nausea and vomiting, and potential complications of cholecystectomy, like infection or hemorrhage. Medical management for clients who have cholecystitis includes a low-fat, high-protein, high-carbohydrate diet. The diet should be low in calories to promote weight loss. Clients may require supplements of fat-soluble vitamins to compensate for reduced absorption. However, some clients may feel too nauseated to eat. NPO, nasogastric suction, and IV infusions may be ordered for clients who are vomiting. Pain relief is essential. Place the client in a low Fowler's position for comfort and teach her to splint the abdomen. Administer analgesics and anticholinergics for pain. Demerol is the analgesic drug of choice because it causes fewer painful spasms of the sphincter of Oddi than morphine sulfate does. Traditionally, morphine has not been administered. Clients who have gallstones may benefit from bile acid therapy, which involves administering oral bile salts to dissolve the stones. Clients may also be given cholesterol-lowering agents that help to reduce the formation of cholesterol stones. When conservative therapy fails to correct cholelithiasis, extracorporeal shockwave lithotripsy may be used to shatter the gallstones. This non-invasive procedure uses powerful, high-pressure sound waves to break the stones into small pieces that can pass through the common bile duct into the duodenum. Following extracorporeal shockwave lithotripsy, make sure you assess the client for increased pain, signs of internal bleeding, and shock. Cholecystitis and cholelithiasis can also be treated surgically. Biliary tract surgery is the most common operative procedure performed on older adults. Cholecystectomy is defined as the removal of the gallbladder. Laparoscopic cholecystectomy is the preferred procedure, and it is performed on an outpatient basis for 80% of clients who have gallbladder disease. The client's abdomen is filled with carbon dioxide to displace the abdominal organs so that they can be more easily viewed on a video screen. The surgeon makes several small puncture wounds in the abdomen, inserts the laparoscope, and dissects the gallbladder with a laser, and then removes it. There is no special preoperative care. The client should ambulate as soon as possible after surgery to promote absorption of the carbon dioxide that remains in the abdomen. Open abdominal cholecystectomy is the traditional procedure, and it is performed when the gallbladder is very distended and inflamed, or contains large, multiple stones. During cholecystectomy, the surgeon will insert a Penrose drain to remove serosanguinous fluid. The surgeon might also explore the common bile duct. A T-tube is inserted to remove gallstones, ensure patency of the duct, and drain bile. Following abdominal cholecystectomy, provide the client with routine postoperative care. Observe the client for bleeding, infection, and respiratory complications, such as pneumonia, thrombophlebitis, and dehydration. If a T-tube is in place, what precautions must you always follow? Make sure to keep the T-tube drainage bag below the level of the suture line to prevent backflow of bile, and never clamp the T-tube without the surgeon's order. In preparation for discharge following abdominal cholecystectomy, provide the client with the following instructions. Inspect the abdominal incision every day for redness, tenderness, or swelling. Report any signs of infection or elevated temperature to the healthcare provider immediately. Open and empty the T-bag every day as instructed, and change the dressing. Keep the T-tube drainage bag free of kinks and below the level of the suture line. Wear loose-fitting clothes to prevent irritation of the wound. Take showers instead of baths to reduce the risk of infecting the open wound. Report excessive or foul-smelling drainage to the healthcare provider. Avoid lifting heavy objects to prevent straining or pressure on the wound site. Do not drive for 6 weeks following the surgery. Reduce dietary fat by avoiding rich sauces, gravies, desserts, and fried foods. Follow the American Diabetes Association's or the American Heart Association's guidelines for planning a low-fat diet. And finally, make an appointment for a follow-up cholangiogram. Now let's talk about the most common reason for emergency abdominal surgery: appendicitis. Acute appendicitis results from obstruction and inflammation of the appendix. The appendix is a small, worm-shaped appendage that is attached to the cecum, the portion of the large intestine that empties into the colon. The appendix is especially prone to obstruction because of its small lumen. As you examine the abdomen of a client with suspected appendicitis, you will note lower right quadrant pain. The pain seems to begin in the periumbilical area and then moves over and localizes in the right lower quadrant. You will also note rebound tenderness at McBurney's point, which is halfway between the umbilicus and the anterior iliac spine. The client may also present with